Hello, good evening, and welcome once again to Dreams. And today's session is a follow up session on the previous talk by Dr. Anshika Gulati on the segmental approach to congenital heart disease. In the last talk, she had discussed about how to approach a congenital heart disease, and today she will be illustrating those principles which she had outlined in the previous talk with the cases. Welcome, Dr. Anshika, for today's talk, and over to you, ma'am, for the
Thank you, sir.
talk.
Thank you. Hello, friends. Very good evening, everyone, and welcome to yet another interesting session. Today, we are on part 2 of the segmental approach of imaging evaluation of congenital heart disease. So let's get started. We are all aware that the congenital heart disease are broadly categorized into two categories, that is acyanotic and cyanotic. So we'll see first how do we approach a case of congenital heart disease on a frontal chest radiograph. Firstly, we'll begin with acyanotic congenital heart disease. So all of these cases have a left to right shunt, which increases the blood flow to the pulmonary artery, leading to pulmonary plethora. Our first step while evaluating a frontal radiograph in a case of acyanotic congenital heart disease is to look for the size of the left atrium. And if you remember in the last class, we discussed the various signs which help us in commenting about the left atrial size on a frontal chest radiograph. So if left atrium is normal in size, there are two possibilities in a case of acyanotic congenital heart disease, that is either atrial septal defect or partial anomalous pulmonary venous connection. On the other hand, if the left atrium is enlarged in size, then we go to our step number 2, that is to look for the size of the aorta. If aorta is normal in size, then the possibility is ventricular septal defect. And if the aorta is enlarged in size, then we are dealing with a case of patent ductus arteriosus. So these are four broad categories: ASD, VSD, PAP-VC, and PDA, and these are together combined into group 1 lesions. Then coming to the next category, that is cyanotic congenital heart disease. Whenever you are looking at the radiograph of a cyanotic baby with congenital heart disease, our first step is to evaluate the pulmonary vascularity. If the pulmonary vascularity is increased, then this is because of admixture lesions, that is, there is mixing of the systemic and pulmonary blood flow, and the possible diagnoses are transposition of great arteries, persistent truncus arteriosus, total anomalous pulmonary venous connection, and double outlet right ventricle. On the other hand, if the vascularity is decreased in a cyanotic baby's radiograph, then this is because of right to left shunt, which takes the blood away from the pulmonary artery, leading to pulmonary oligemia. In that case, we go to our step number 2, that is to look for the heart size. If the heart size is normal, then there is one possibility, that is TOF, tetralogy of Fallot. If the heart size is increased in such a case, then there are two major possibilities. Either it could be Epstein's anomaly or pulmonary stenosis. And these cyanotic congenital heart diseases are further categorized into group 2, 3, and 4, as we shall discuss further. So starting with group 1 lesions first, and we have discussed that all acyanotic congenital heart diseases fall into the group 1 category. So we'll deal with them one by one. From this table, we know that group 1 lesions are all acyanotic congenital heart diseases. All of them have a left to right shunt, which increases blood flow to the pulmonary arteries, leading to pulmonary plethora, and we'll differentiate them by the left atrium and the aorta size. So acyanotic left to right shunt with pulmonary plethora and cardiomegaly seen in all these cases. Starting with the atrial septal defect first. So this is the most common congenital heart disease in adults. The pathophysiology is such that there is a defect in the interatrial septum, which leads to shunting of blood from the left to the right side, because the pressures on the right side are low. So there is blood flow from left to right, and this leads to volume overload in the right atrium and then the left right ventricle, and ultimately increased blood flow to the pulmonary arteries. And these patients are usually asymptomatic in childhood, and they present in adulthood with two major complications. One, there is pulmonary artery hypertension because of long standing increased blood flow to the pulmonary arteries. And second, because of atrial dilatation, there is stretching of the wall of the atria, which leads to tachyarrhythmias, mostly atrial flutter and atrial fibrillations. So what happens? There is stasis of blood within the right atrium, which can lead to thrombus formation. So these patients present in adulthood with features of thromboembolic stroke. This is about the embryology of the atrial septum. So to begin with, there is a one common atrial cavity. Then the septum primum falls from above like a curtain, and there is still a patency in the lower part of the septum primum, which is known as the ostium primum, and ultimately it falls down completely to the level of the endocardial cushions and completely dividing the right and left atria. Then a hole develops within the septum primum, which is known as the ostium secundum. Then next step is another curtain falls from the right side, which is known as the septum secundum. Then it falls completely up to the level of the endocardial cushion and covering the septum, covering the ostium secundum. After that, another hole develops within the septum secundum, which is known as the foramen ovale. In most of the cases, it closes after the birth, but it may remain patent in some cases. We'll see how we differentiate between ASD and patent foramen ovale. So broadly, ASD can be of four types. Most common is the ostium secundum, which is within the floor of the foramen ovale in the central part of the atrial septum. Second category is the ostium primum, which is in relation to the endocardial cushions. Third is sinus venosus, which actually refers to partial opening of either SVC or IVC into the left atrium. The fourth category is coronary sinus defect, which refers to the opening of coronary sinus into the left atrium. So on frontal radiograph, we'll see right-sided cardiomegaly because of volume overload to the right side. And also we'll see signs of pulmonary plethora because of increased vascularity across the pulmonary arteries. This was a case that came to us, a 4-month old baby. If you see, the cardiac size is definitely enlarged. We discussed the cardiothoracic ratio last time, and this is RV type of cardiomegaly because the apex is pointing upwards, and there is pulmonary plethora, the increased vascularity in the lungs. Also, the diagnosis was confirmed on echocardiography. There is right-sided cardiomegaly definitely, and there is a large ostium secundum type of OSD with left to right shunt, and ostium secundum OSD is most common, and it is located in the site of the foramen ovale only. So how do we differentiate it from a patent foramen ovale? PFO is usually less than 3 millimeters in size, and there will be turbulent flow seen on Doppler in PFO versus OSASD. And how do they treat? It is treated now in cath labs only with a catheter is passed across the femoral root, and this septal occluder is placed at the site of the defect to close the ASD. Second in this category is partial anomalous pulmonary venous connection. We know that there are 4 pulmonary veins that are draining into the left atrium. If one or more of these pulmonary veins, but not all of them, drain into the right atrium or any one of its tributaries, then that condition is known as PAP-VC. This is a case that had come to us. If you see, there is definitely right-sided cardiomegaly. So the pathophysiology will remain the same. There will be increased blood flow to the right side of the heart and ultimately to the pulmonary arteries, leading to pulmonary plethora. So again, we'll have right-sided cardiomegaly. And if you notice, the superior and the inferior pulmonary veins of the right side are draining well into the left atrium. The inferior pulmonary vein of the left side is also draining into the left atrium. But if you see, the superior pulmonary vein of the left side is going superiorly into the and draining into the left brachiocephalic vein. So this is partial anomalous pulmonary venous connection. on the left side. And this is one of the favorite spotters that is kept in exam. This is the scimitar vein, which is PAP VC on the right side. The inferior pulmonary vein of the right side is draining into the inferior vena cava. This is because of its characteristic shape that looks like a sword. It is known as the scimitar vein. And if it is associated with right lung hypoplasia, then it is known as the scimitar syndrome. And there can be other syndromic associations also, like the sequestration of lung or horseshoe lung. But just remember this radiograph, often kept in spotters. Bilateral PAP VC also we can have, but that is very, very rare. The third lesion in this category is the ventricular septal defect, which is the most common congenital heart disease in children. Uh, we just discussed that most common congenital heart disease in adults is ASD, but in children it is VSD. Why so? Because the very small VSDs uh, close spontaneously in childhood themselves, so they do not always go up to adult life. And how do these children present? They present with breathlessness and feeding difficulties soon after birth. As the pulmonary vascular resistance gradually drops, so these babies become symptomatic. The physiology of VSD is that uh, just see, there is a large defect in the interventricular septum and the left ventricle. It has to deliver the blood to the systemic circulation, also the aorta, and also to the right side of the heart, because there is reduced pressures on the right side. So now there is a huge volume overload in the left ventricle, which has to supply blood to both the sides. So there will be LV, volume overload. Ultimately, the end diastolic pressure of the left ventricle will increase. That will lead to enlargement of the left atrium as well. And then ultimately back pressure to the pulmonary veins, and also increase blood flow to the pulmonary arteries. So there will be pulmonary plethora along with left-sided cardiomegaly. And ultimately, in long-standing cases, when there is increased blood flow to the pulmonary arteries, there will be pulmonary vasculopathy affecting the smaller vessels in the lungs, leading to permanent damage, which will cause pulmonary artery hypertension, and ultimately there will be reversal of shunt. This is known as Eisenmenger syndrome. On the basis of the location of defect within the interventricular septum, VSDs can be of 4 types, most common being the perimembranous. Others can be inlet VSD, outlet VSD, or the trabecular or muscular VSD. This was a case that had come to us, like I just mentioned. There will be cardiomegaly, but the apex will be pointing down and out only, because it is predominantly the left-sided cardiomegaly, and there will be pulmonary plethora. The pulmonary arteries will be dilated. And when this case progresses to complication like Eisenmenger, there will be increasing of pressure on the right side of the heart, which will reduce the left to right shunt, leading to spurious normalization of the heart size. And this we have seen left-sided cardiomegaly with pulmonary plethora, and the same was confirmed on the cath angio study as well, with the blood flowing across the interventricular septum from left ventricle into the right. This was a case, 3 years old baby who came to us with feeding difficulties. The scanogram shows us a huge LV type cardiomegaly with pulmonary plethora, and we did a cardiac CT for this patient, and what we found was there was a mid-muscular VSD. This is the defect in the interventricular septum. And the same was shown on a oblique section also. This is the left atrium, this is left ventricle, this is the root of aorta, this is right ventricle with the moderator band, and this is the mid-muscular VSD. We can see that on the short axis view as well. This is right ventricle, left ventricle, and this is the defect within the interventricular septum. The treatment for VSD, there are 2 options depending on the size of the defect. Either they can put a patch there, or they can just primary suture if the defect is small. Fourth lesion in group 1 category is the PDA. So ductus arteriosus is a normal connection in the fetal life, connecting the proximal part of the descending thoracic aorta to the proximal part of the left pulmonary artery. And usually it closes on day 1 of life, but it may remain persistently open in preterm babies, or secondly, in some cyanotic heart diseases which are PDA dependent, like transposition of great arteries. We'll discuss them just now. And in PDA cases, the radiograph will look just like VSD, except for there will be enlargement of the aorta as well. That is the differentiating feature between VSD and PDA on radiograph. On cross-sectional CT and MR, we classify PDA in according to Krichenko classification. The type A PDA is a conical type with broad base towards the aorta and narrow the apex towards the pulmonary artery. Type B is short and broad. Type C is long and tubular. Type D has a lot of constrictions and aneurysmal dilatations within. And type E is also a constricted type. There is a single constriction at the pulmonary end. So the clinical implication of this classification is that type D and type E are not suitable for surgery. Coming to group 2 lesions now. As we discussed that the cyanotic heart diseases are classified into group 2, 3 and 4. And in the group 1, the major disease entity is TOF, in which there will be cyanosis, there will be decreased pulmonary vascularity because of a right to left shunt, and there will be no cardiomegaly. So cyanotic heart disease with right to left shunt, no pulmonary vascularity, decreased pulmonary vascularity and no cardiomegaly. So in TOF, this is the most common congenital heart disease, and we'll discuss the embryology. So last time I mentioned that this is my favorite section on the cardiac CT. Why? Because this one section at the level of the aortic and pulmonary valves will give you a lot of information. Firstly, it will tell you about the ventricular looping. Second, it will tell you about the relationship of the great arteries, and now it will tell us about the embryology of TOF. So what happens? This is the pulmonary artery, this is the aorta, and this is the septum dividing the two, the conal septum. So in TOF, what happens? This conal septum is displaced anteriorly. So what will that cause? If this septum is displaced anteriorly, the pulmonary artery will be small in size, there will be infundibular stenosis, the aorta will be large in size, overriding aorta, and also normally this conal septum has to align with the interventricular septum. But if it has displaced anteriorly, it will not sit properly on the interventricular septum. So there will be a ventricular septal defect, which with the aorta overriding it, and because of the infundibular stenosis, there will be increased pressure in the right ventricle, leading to RV hypertrophy. So that is the tetrad of TOF: pulmonary infundibular stenosis leading to RV hypertrophy, and malalignment of the conal septum leading to VSD with aorta overriding it. And then there can be certain variants of TOF, like pink TOF if there is only mild pulmonary stenosis, pentology if it is associated with atrial septal defect also, and trilogy if there is no VSD at all. Instead, there is PFO. So this was a case of a 15-month-old baby girl, and the scanogram, it shows us the classical boot-shaped heart with the upturned apex, and there is concavity in the region of the pulmonary conus. So classical boot-shaped heart. And we did a CT, and these are the findings that we got. This is a tight infundibular stenosis of the pulmonary artery, and just look at these. These are thread-like pulmonary arteries, very small, hypoplastic. And this is the short axis view, which shows us there is huge RV dilatation along with hypertrophy of the RV wall. Also, we see there is this subaortic VSD, and this aorta is overriding, straddling on the ventricular septal defect, having blood supply both from the left and the right ventricle. And this section also shows the same, the VSD with aorta overriding it. We can see this complete case also. Similar findings: tight infundibular stenosis with thread-like pulmonary arteries, RV hypertrophy, and subaortic VSD. This is the subaortic VSD. One important thing that we have to comment in cases of TOF is these are MAPCAs, the major aortopulmonary collaterals, because you see there is tight infundibulous stenosis. The pulmonary arteries are very thin thread like. So where are the lungs getting their blood supply from? The lungs are getting their blood supply from these collaterals, the major aortopulmonary collaterals. And while reporting, we have to mention about the origin, the size of all these collaterals, because in surgery, they have to close each one of them. So for surgery, there are two options. Either they go for palliative modified Blalock Taussig shunt, which involves putting an implant between the subclavian artery and the pulmonary artery. And the surgical repair, it has to happen in two steps. First, they'll close the VSD and they have to reconstruct the RVOT, which is stenosed in these cases. Coming to group 3 lesions. In group 3 lesion, the major disease category is the Epstein's anomaly, which will have cyanosis. Clinically, the pulmonary vascularity will be reduced because of a right to left shunt, and there will be cardiomegaly. So cyanotic heart disease with right to left shunt with decreased pulmonary vascularity and cardiomegaly. This is Epstein's anomaly. So what happens in Epstein's anomaly? The tricuspid valve in these cases is very redundant and it is prolapsed towards the apex of the heart. That is one. Secondly, it is also adherent to the wall of the right ventricle. So there is decreased coaptation, means there is no closing. The tricuspid valve is very incompetent. So there will be reflux of blood across the tricuspid valve, leading to TR, tricuspid regurgitation. And there will be smaller functional right ventricle. This part of the right ventricle has now in effect become part of the right atrium only. And because of this adhesion of valve to the wall of the right ventricle, there will be outflow obstruction in the RV. So if you see, there is volume overload in the right ventricle. So now it has to drain somewhere, because the blood that is going from RA to RV is coming back because of incompetence of the tricuspid valve. So there is an obligatory ASD, which leads to a right to left shunt. And on CT and MR, we classify Epstein's anomaly according to Carpentier classification, depending upon the size of the residual right ventricle. And second point to look for is the amount of obstruction to the RVOT. On frontal radiograph, so clinically these babies are cyanotic, and secondly, because of increased blood in the right atrium, there is back pressure in the IVC, leading to congestive hepatomegaly also. And on radiograph, we'll see a hugely dilated box-shaped heart with pulmonary oligemia. And on MR, so last time we discussed that normally also the tricuspid valve is located slightly towards the apex as compared to the mitral valve, and the distance between the two is known as the offset. So the diagnostic criteria for Epstein's anomaly is that if the offset increases more than 1.5 centimeters in children or more than 2 centimeters in adults, then it is known as Epstein's anomaly. So this is a 4-chamber SSFP cine image, which shows us this is the tricuspid valve, which has prolapsed far towards the apex, leading to atrialization of this right ventricle, and only this much is the residual functional right ventricle. So what do? We on this 4-chamber view only, we calculate the area of the right atrium plus the atrialized part of the right ventricle. We add these two areas, and secondly, we add the areas of all the 3 remaining chambers, that is LA plus LV plus functional RV, and we calculate their ratio to get the Seller-Mayer index. And if this index is more than 1, then this is a poor prognostic indicator in these babies. Treatment. They will first have to replace this tricuspid valve, which is redundant and incompetent. Then they will have to plicate this atrialized part of the right ventricle, and they will have to close this ASD. So 3-part surgery. Coming to group 4 lesions. These are again cyanotic heart diseases with increased pulmonary vascularity because of mixing of the pulmonary and systemic blood flow. And there are four major disease categories: TGA, persistent truncus arteriosus, TAP-VC, and DORV. We'll see them one by one. So cyanotic heart diseases, admixture lesions with increased pulmonary vascularity and cardiomegaly. First in this category is TGA, which is transposition of great arteries, which by definition means that the aorta is now arising from the right ventricle and pulmonary artery is now arising from the left ventricle. So you see there are two parallel and independent pulmonary and systemic circuits that are running. The pulmonary circuit on the Okay, so there has to be some mixing in the between the right and left side if it has to be compatible with life. So either ASD, VSD, PFO, PDA, there has to be some connection between the right and left side. And in the last class, we discussed that this TGA can be of two types, DTGA or LTGA, depending on the location of the pulmonary artery depending on the location of the aorta in relation to the pulmonary artery. If aorta is on the right side, then it is DTGA. If aorta is on the left side, it is LTGA. So this was a case of a 1-month-old baby girl who presented with cyanosis since birth. And we see there is cardiomegaly with down and out pointing apex with a narrow vascular pedicle and pulmonary plethora. The classical egg on side heart of TGA. We did a CT for her. We'll follow the segmental approach that we learned last time. So our step 1 was situs. The liver is on right side, so situs solitus, that is step 1, which means the right atrium is on right, the left atrium is on left because of the rule of visceroatrial concordance or veno-atrial concordance. Step 2 is ventricular topology. So by loop rule, we'll see ventricular topology. This is aorta. And this is pulmonary artery. So you see in this case, the aorta is anterior and to the right of pulmonary artery. So this is D type of ventricular looping. And third was relationship between great arteries. So aorta is anterior and to the right. So this is DTGA. So first 3 steps of the segmental approach done: situs solitus. Second, D loop ventricular topology. Third, the DTGA type of arrangement of the great arteries. Then coming to the fourth step, that is AV relations. By D topology, we mean that the right ventricle is on the right side, and we see the moderator band also, and the left ventricle is on the left side. So RA on right, RV on right, there is AV concordance. LA on right, LV on right, AV concordance again. Then fourth step was VA relation, that is ventriculo-arterial relations. So this is the aorta, ascending aorta, descending aorta. Follow the ascending aorta down. Where is it arising from? It is arising from the right ventricle. Now look at the pulmonary artery. This is the pulmonary artery. Follow it down to look for the origin. It is arising from the left ventricle. So RV giving rise to aorta and LV giving rise to pulmonary artery, which means there is ventriculo-arterial disconcordance. Then what was our sixth step was to look for the connection. Can you make out? This is a D type of TGA, which means there are 2 parallel circuits running. So if this has to be compatible with life, there has to be some connection between the right and left side. And where did we find the connection? This is the patent ductus arteriosus, PDA. So our complete report for this case will be situs solitus, D type of ventricular topology, D TGA with AV concordance, with VA disconcordance, and type C PDA because it is long and tubular. This is the sagittal section showing the PDA, which is long and tubular, that is Krichenko type C PDA. And this is our final report according to the segmental classification or the Van Prague notation. Another case, This was a 15-month-old girl with cyanosis since birth. Again, we'll follow the segmental approach step by step. Okay. So situs is solitus, liver on right, stomach, spleen on left, situs solitus. Come up. This is one atrium. This is the other atrium. This is one ventricle and this is the other ventricle. So this is the interatrial septum, interventricular septum. It is pointing towards the right side. The apex of the heart is pointing to the right. So this is dextrocardia. So this is situs solitus with isolated dextrocardia. And if you remember, we discussed last time that this arrangement is associated with a large number of congenital heart diseases. So step 1 is done, situs solitus. Step 2 is ventricular topology. This is one ventricle with smooth septal surface. So this is morphological left ventricle. And this is the other ventricle with this moderator band. So this is morphological right ventricle. So RV is on left side in this case. This is L type of ventricular looping. And from situs solitus, we know by the rule of veno-atrial concordance that this is RA, this is LA. So can you make out what is happening? RA is on right. This is RA. It is draining into morphological left ventricle. This is LA, which is draining into morphological right ventricle. So there is AV disconcordance. Coming to the third step, the relationship of the great arteries. This is pulmonary artery, this is aorta. Follow them down to their origin. This is aorta, this is pulmonary artery. So aorta is anterior and to the left of pulmonary artery. So what is this arrangement? This is LTGA, levotransposition of great arteries. And if you follow their origin, this pulmonary artery is arising from this morphological left ventricle and the aorta is arising from the morphological right ventricle with a subaortic conus. This is the conus, which suggests that the aorta is arising from the morphological right ventricle. So till now, what all do we have? We have situs solitus with AV disconcordance, with L type of TGA, with VA disconcordance. Then coming to the final sixth step, that is to look for the individual morphological defects. If you look carefully, there is an ostium secundum type of ASD, and also there is a subpulmonic VSD. We'll see in other sections also. So situs solitus with dextrocardia with this subpulmonic VSD or secundum type of ASD. This is also showing the subpulmonic VSD. And if you look at this section, this is aorta and this is the subaortic conus, which suggests that aorta is arising from the right ventricle, meaning there is VA disconcordance. And this is pulmonary artery with fibrous continuity with the AV valve, suggesting that pulmonary artery is arising from the left ventricle. So our final report will look like this: situs solitus with dextrocardia, with L loop ventricular topology, with LTGA, with AV disconcordance, with VA disconcordance, with OSASD and subpulmonic VSD. I hope all these steps are clear by now. This is the 6-step approach that we discussed last time. So there are various treatment options for TGA. Second disease entity in group 4 category is TAP-VC, that is total anomalous pulmonary venous connection. Now all the 4 pulmonary veins will drain into right atrium or one of its tributaries, maybe SVC, IVC, portal vein, hepatic veins. Any of the systemic vessels will receive the drainage from the pulmonary veins. And depending upon the type of the drainage, TAP-VC can further be classified into supracardiac, cardiac, infracardiac, or mixed type. So this is the normal drainage. All the 4 pulmonary veins are draining into the left atrium. In the supracardiac type, all the 4 pulmonary veins will form a common channel which will drain into a vertical vein, draining into the brachiocephalic and ultimately into the SVC and right atrium. This is the supracardiac type. In the infracardiac type, all the four will form a common channel and form a vertical vein descending down and draining into the IVC or hepatic veins or even portal vein. And there will be a constriction at the level of the diaphragm. So this is known as obstructive type of TAP we see. And this is the cardiac type, in which all four of them forming a common channel draining into the coronary sinus. This was a 9-year-old girl who presented to us with dyspnea and recurrent chest infections. And you see, this is the scanogram showing the classical snowman heart or figure of 8 appearance, and the corresponding coronal section of cardiac CT shows that the superior mediastinal widening is because of this vertical vein and dilated SVC. We'll see the complete case. So these are the superior and inferior pulmonary veins of the right side and the superior and inferior pulmonary veins of the left side. All of them are forming this common channel which had no connection with the left atrium, and it is draining into this vertical vein which goes up and drains into the left brachiocephalic. Here it is going and draining into the left brachiocephalic and ultimately into the superior vena cava, which is dilated, and this leads to the superior mediastinal widening, giving the classical snowman appearance or figure of 8 appearance on the radiograph. And this is the VRT, the volume rendered image, which beautifully shows that all four pulmonary veins are forming this common channel which is draining into the vertical vein, which is draining into the left brachiocephalic and ultimately into the SVC. Another disease entity in this group 4 is a DORV, that is double outlet right ventricle, which by definition means that both the great arteries, the aorta and the pulmonary artery, are arising from the right ventricle. And the 50% rule states that if more than 50% of a valve of the great artery is arising from the RV, then also we will say that that artery is arising from the RV. So now, if both the great arteries are arising from the right ventricle, the left side also has to drain somewhere because it is getting blood from the pulmonary veins and LA. So there is an obligatory VSD in all these cases. And depending on the type of the VSD, the DORV can again be of 4 types, like we discussed the types of VSD. And there will be bilateral conus, because I mentioned last time that any artery arising from the right ventricle will have a conus below it. So now both the arteries are arising from the right ventricle, so there will be a bilateral conus. And depending on the origin of the, if pulmonary artery arises entirely from the RV and more than 50% of aorta arises from the RV, then we say that it is concordant VA connection. And if entire aorta arises from RV and more than 50% of pulmonary artery arises from RV, we say it is disconcordant VA connection in a case of DORV. Obligatory VSD we have discussed. The final thing that we have to mention in cases of DORV is about the pulmonary stenosis, if the pulmonary blood flow is restricted or it is unrestricted. We'll see a case. And again, we'll follow the segmental approach that we have learned so far. The 6-step approach. First step is to look at the situs. So liver IVC on right side. This is situs solitus. Situs solitus by the rule of veno-atrial concordance tells us that this is RA, this is LA, and apex is pointing to the left. So this is situs solitus with levocardia. Second step is the ventricular topology. So if you notice, there is a single large ventricular cavity and the other one is this. the smaller compressed ventricle. So, but now this huge ventricle, whether it is morphological right or left, that we do not know, because this is aberrant morphology. So we'll go to the loop rule, which told us that aorta is on the left of pulmonary artery. So this is L type of ventricular topology, which means that the RV is on left side. So by loop rule, we can say that this is the morphological right ventricle and this smaller one is the morphological left ventricle. So now going to the step 3, that is relationship of the great arteries. This is pulmonary artery, this is aorta. So aorta is anterior and to the left of pulmonary artery, which means there is LTGA type of relationship of great arteries. Fourth step is AV relations, that is atrioventricular connections. So veno-atrial concordance has told us that this is RA, this is LA. Loop rule has told us that this is RV, this is LV. So RA to LV and LA to RV. So there is AV disconcordance. Then step 5 is ventriculo-arterial connections. If you trace this pulmonary artery to its origin, we'll see that it is arising from the morphological right ventricle. And we'll trace the aorta. This is the aorta. We'll trace it down to its origin. And we notice that more than 50% of aorta is arising from the morphological right ventricle only. And there is this subaortic VSD, if you notice. This is the ventricular septal defect, which is just below the origin of the aorta. So more than 50% of aorta is still arising from the morphological right ventricle only. So we say that there is double outlet right ventricle with concordant ventriculo-arterial connection, because pulmonary artery is entirely arising from RA, RV, and aorta is arising more than 50% from the RV. So the VA connections are still concordant. So our final report in this case will be situs solitus with L loop ventricular topology, because aorta was on left side, RV was on left side, LTGA because aorta was anterior and to the left of pulmonary artery, with AV disconcordance, with double outlet right ventricle, with VA concordance and subaortic VSD. And also I just told that in DORV cases, it is important to comment about the type of pulmonary blood flow. So we see the pulmonary arteries are good in size. So, and there is no pulmonary stenosis. So we all see good size pulmonary arteries, no pulmonary stenosis. So finally, we'll mention that there is unrestricted pulmonary blood flow. And this completes our 6-step approach of segmental evaluation of congenital heart disease. And this is the Van Prague notation. Thank you.
Thank you, ma'am. Please put your questions in the chat box.
If there are any questions, I'll be happy to answer.
Thank you so much, ma'am. At present, there are no questions.
Okay.
We'll just wait for 30 seconds, ma'am.
Sure, sure.
There are no questions, ma'am. So for now, we end this session. We really look forward to your next session, ma'am, because this was a really good session and you made it really simple for all of us.
Thank you.
Yeah, thank you, ma'am. So good night, everybody. Good night, ma'am.